Good afternoon. This is again Professor Triple N or Nick PA from Brooklyn, New York. This is my part two of emergency medicine board review sessions or notes for PAs and MPs. Today is Sunday, April 10th, 2 p.m. in the afternoon. Once again, if you have any questions or advice or suggestions, please feel free to email me. My email is nick, M like Mary, D like dog, the number 1 at Gmail. Let's start from. Let's talk about. We finished with mercury poisoning, but let's go over again. Basically, mercury poisoning. We have when we have ingested mercury orally. This can cause neurological problems. Inhaled mercury vapor produces lung toxicity, which presents initially with interstitial fibrosis. Neurological problems present with patients which are nervous, jittery, uh, twitching, and sometimes hallucinating. Basically, there is no therapy to reverse the pulmonary toxicity. Chelating agents which can remove the mercury from the body, and these chelating agents are such as dimethyl-caprol and succimer are effective for removing mercury from the body and decrease the neurological toxicity. This can prevent progression of the pulmonary disease, but cannot reverse it. Let's talk about here about toxic alcohols like methanol and ethylene glycol. Both methanol and ethylene glycol produce toxicity and metabolic acidosis with increased anion gap. Both give the osmolar gap, and they are both treated with fomepizole and dialysis. And here there is a nice table of the differences between methanol and ethylene glycol toxicity. The source for methanol toxicity is wood alcohol, cleaning solution, paint thinners. For ethylene glycol, this is antifreeze. Uh, toxic metabolites. For the first one, this is formic acid or formaldehyde, and for the second is oxalic acid or oxalate. Presentation, usually methanol presents with ocular toxicity and ethylene glycol presents with renal toxicity. The initial diagnostic abnormality, this is renal inflammation, and the second one uh, can be diagnosed by hypocalcemia, envelope-shaped oxalate crystals in the urine. Let's discuss so-called osmolar gap. The osmolar gap is the difference between the measured serum osmolarity, and let's go to the next page. Let's continue. So there is a clinical vignette here, which we said that the right answer is A. Because of a loss of skin, there is a massive loss of body fluids and albumin. Fluid loss, if fatal, will occur immediately. After several days, a loss of protective barrier to the skin lead to infections with staphylococcus. Also, rhabdomyolysis causes renal failure, especially combined with volume depletion, which decreases the renal perfusion. There is not a most common cause of death. Leg injury is the immediate cause of death. There is a clinical tip which states that prophylactic topical antibiotics such as silver sulfadiazine is routinely used, not IV antibiotics. Let's go to the next slide. We have a nice table of heat disorders. The first one is heat cramps or exhaustion. The second is heat stroke. The third one is neuroleptic malignant syndrome, and the last one is malignant hyperthermia. For the risk for the first one, this is high outside temperatures. The body temperature is usually normal. CPK and potassium level is normal, and the treatment is oral fluids and electrolytes. For the second category, which is heat stroke, again, risk is from high outside temperature. The body temperature here is elevated. CPK and potassium are elevated, and the treatment is IV fluids and evapolarization. Then the third category, this is neuroleptic malignant syndrome. We have these from risk of antipsychotic medication. Both the temperature, CPK, and potassium are elevated. The treatment with dantrolene or dopamine agonist. Also, we can use bromocriptine and cabergoline. We have another fourth clinical category here, which is malignant hyperthermia. Is when you the risk is when you use anesthetics and they are used systemically. Both body temperature, CPK, and potassium was elevated, and the treatment is with dantrolene. Let's discuss so-called hypothermia. Hypothermia is when we look for intoxicated person with a low body temperature. Unintoxicated people do not fall asleep outside in cold temperature. The most common cause of death from hypothermia, this is cardiac arrhythmias. The best initial test is EKG. This is slide 13. We will see on figure 1/4 the EKG of a person which has hypothermia, and this results in marked elevation of the J point or J waves, and you will see that the J waves are where the QRS hits the ST segment. There is no ST elevation or right bundle branch blocks. All of these abnormality normalize when the patient is has a rewarming. Let's talk about next clinical category, which is drowning. We need to manage the airways and administer positive pressure ventilation. Number one, steroids and antibiotics are not effective, not beneficial. Number two, salt water drowning act like CHF with wet, heavy lungs. And number three, freshwater drowning will cause hemolysis from absorption of hypotonic fluid into the vasculature. And there is a clinical tip here. The wrong answer for drowning includes steroids, antibiotics, and this is the end of the lecture for part 2 of Emergency Medicine PANP Note. If you have any question or suggestion, please feel free to email me on my email, which is very simple, NICK, M like Mary, D like dog, the number 1 at gmail.com. Thank you so much. See you in part 3.